I wanted to point out we're talking about medical issues this half hour of the program. And then in the next half hour, I'm going to be joined by Nathan Jerky. He's joining us from the state highway department, and he's going to be talking with us about roads and road conditions. We'll have some more stories on that myself I'll share with you. But in the meantime, Russell Singleton is joining us from Trip Family Medicine, and we're picking up first of all, welcome back.
Thank you.
Want to point out it's 8:34. We're at 72. Bill Colley with you as well this morning on News Radio 1310, KLIX, and News Radio 1310.com. Better Health with Trip Family Medicine. And Russell, we're picking up where you left off the last time you were here, as I understand.
Yeah, a few weeks ago we started to talk about the drug epidemic. I think we covered a lot of the various substances out there. I think we talked a little bit about tobacco, alcohol, marijuana, meth, and opiates, but we didn't really get a chance to take it to the next step and discuss what we can do about it. Because what good is it to complain without at least coming up with a few solutions?
And solutions, though, many solutions. Some people, unfortunately, have to be locked away to get a solution before the intervention happens. But sometimes the solutions are a little bit easier.
Yeah, I agree. I've seen that in my professional life and in my personal life. Friends and family do have to unfortunately hit rock bottom, and so we could probably have a whole nother discussion about what you can do as a parent or a sibling or a caregiver, a loved one of someone who is abusing drugs, and how you can support them, how you shouldn't support them, how you should help them acknowledge and accept consequences of their actions. But today I wanted to talk a little bit about what you as the patient can do. And actually, before that, I wanted to talk about what we as providers can do. I'll make a pledge to you and and commit to treating you appropriately, but in such a way that we can together limit the growth of this problem.
You know, you talk about how you get involved, and it does sometimes take some people on the outside. Years ago, I saw an Andy Griffith movie where he played a fellow who was very active in his church, and he was supposedly a very good community member. But the movie was about how he had a drinking problem, and nobody knew about it. And he would literally, as an usher, he would, after everyone was seated, he'd be in the back of the church with a little flask, and he'd be drinking out of it. And the movie detailed how it eventually hurt the family, and it was no pun intended, but it was a very sobering movie to see. Uh, but we have new medicines today too, though, that help people who have these problems. Where we just touched on this briefly the last time you were here a few weeks ago, but we're having some medical revolutions out there that are leading people away from that substance abuse where they feel they need it.
Yeah, there are a few, or at least a compound that's currently being developed and tested to treat people with chronic pain. So it's technically an opioid. It hits those same opioid receptors, but not all of the same ones that our traditional opiates do, like your Norcos, your Vicodins, your
Hmm.
Oxycontins, because some of those receptors shut off pain signals, but other receptors trigger euphoria. And that is what causes people to use and abuse these medications more than they should. And it's because of that euphoria. And I think we talked a little bit about last time how not only is there an immediate reward, but then that starts to trigger dopamine pathways in the brain, and physiologically there's a dependency that is occurring without you ever knowing about it and without you ever um, wanting it to happen. It just that's the way the body works.
I've had a number of friends who've gone through 12-step programs that I've met through work and through life. Uh, those are still one of the oldest programs, obviously, if not the oldest. It seems to work though for a lot of people. If maybe not all, but it seems to work for a lot of people. That's still available.
Yeah, absolutely. I think we have chapters or groups of AA here in our area. And if I'm not mistaken, I believe there also is what they call OA, or the equivalent groups for people who abuse other substances. As a provider, though, there are a couple of things that we're going to do. The CDC just released some new guidelines on both acute and chronic prescribing of these, and it actually is, I don't want to say revolutionize because that's maybe too strong of a word, but it sets a clear standard. For example, acute pain and if we're talking about narcotic use, should be covered for ideally 3 days or less. And I think that's a pretty good guideline, but I also have people who have fallen and fractured a rib, and they have a hard time breathing for a month. And then, the next month they're healing. The CDC goes on to say that even though that 3-day window is the goal, it's acceptable to prescribe up to a week, but then at that point, no more. That's huge. So limiting the amount of prescriptions that we as providers are giving out is one thing. Um, Another thing we're going to do is, I guess, the other side of that coin, and it's to commit to treat your pain. We're not going to ignore the fact that you're in pain. I'm also going to be a little bit suspicious though if you tell me your pain is 10 out of 10 and you're texting your boyfriend or your girlfriend. I mean, we're not stupid, but we're, we're going to treat your pain, and if it's not with a narcotic, we will find something, because not treating pain is not an option.
We've got more coming up. We want to point out, too, as well. If you got a question or comment about this because it impacts everybody's life, feel free to give us a call at 736 0300, 736 0300. Short break on the way, though, in just a moment, and I hope you can stick around. Russell Singleton is a physician assistant at Tripp Family Medicine in Twin Falls, and he's joining us this morning. Better Health with Tripp Family Medicine. And of course, we're talking about, well, again, I think you brought this up, Russell, a few weeks ago. There's a difference. Addiction is a different thing than the medical terminology.
Yeah, and I think we want to be very clear about that. Addiction actually is not a medical term, where in medicine we would use the term dependency, that you have a physiologic need for that substance to continue your baseline level of functioning. Where I think addiction is a little bit more broad, and that refers to some of the destructive habits that you'll engage in to continue seeking the substance on which you're dependent. It refers to all the negative aspects of your substance use.
And just quickly for people listening this morning, I wanted to point out the doctor's office, Dr. Tripp's office, is still looking for new patients. And we say generally, we don't say always, but generally, if someone calls in the morning and they've got a serious medical issue going on, you can generally see them in the same day or within 24
Yeah,
hours.
and today I would remind parents and I guess even youth out there that today we're doing a sports physical clinic in the afternoon. We're going to go a little bit longer today until 6 p.m. And what's unique about this is not only can we get you in quickly, do your sports physical, get you out the door, but you may not have to pay anything at all. If you have a wellness provision on your insurance, it won't cost you a dime. But beyond that, we're making donations from every physical we do, and from every dollar we collect, we're making a significant donation to the team of your choice.
Wanted to point out too as well, if someone would like to call the office, how do they go about doing that?
933-4400, whether it's for that sports physical clinic or for your cough and cold or backache even, uh, give us a call, and we'll get you in as soon as we can.
And also online and on Facebook.
Yeah, we are on online, trippfamilymedicine.com, TRIPP, and then we're on Facebook, we're on Twitter, so come join the fun.
We're talking a little bit about the problems people have with dependence. And from a medical perspective, you said the focus today is really solutions. And sometimes it's different medications, sometimes it's just an intervention. Uh, but if someone comes into the office and first of all, they've got to say, I've got a problem. I mean, you might be able to detect it, but there's always that point that says you've got to admit it first. But once they do that, what happens next?
Well, um, ideally, if we have someone who's using opiates, and that's kind of the theme for today, ideally we'll taper them down about 10% a week over the subsequent weeks and months until they're off, because that avoids withdrawal symptoms, and withdrawals are terrible. It's like having a severe case of the flu. You just feel sick, you feel terrible. However, withdrawing from opiates is not life threatening. We talked a little bit about this last time. Withdrawing from methamphetamine is not life threatening. Where someone who is an alcoholic and they try to quit cold turkey, they're actually in a very delicate situation. They could have a seizure, they could develop what's called the DTs, and it's a serious issue. The benzodiazepines like Ativan, Valium, Xanax, Librium, all those can also be very dangerous to withdraw from. They can precipitate a seizure as well.
People have different, obviously, physiologies, and back when I used to use tobacco, and I smoked a lot of cigars when I was younger, and would smoke a pipe occasionally and smoke cigarettes with friends. When I decided to quit, it was rough for 3 days. I've heard people say they had 18 months where it was rough. For me, 3 days. For 3 days, I wanted to sit down and smoke something, and then suddenly it was gone. So it depends on the individual, right?
Yeah, and especially with some of those social vices, I guess, because so much of it is not the substance itself, but it's the way it has incorporated itself into your social life. You drink with friends, you take your smoke break at work, and you just have these habits that have formed over a lifetime. And even after you're physiologically free of the substance, your life oftentimes still has a giant void. And if you don't fill that with something, you're going to be hurting, and you're going to likely relapse.
We have a caller with us, and wanted to point out telephone number to reach the show today, 7360300. Caller, you're on the air. Go ahead.
Yes. Have you guys ever heard of Kratom? It's a leaf from Asia, and it's a replacement for the opioids, and it's helping folks with their withdrawal symptoms. Instead of having to go to methadone or something like that, they're actually this natural plant seems to do a pretty good job. Any ideas on that?
Actually, I haven't, and I will look into that. That's interesting. I think it brings up a good point, though. Are there alternative ways to treat pain, or are alternative ways to help people come down from these types of addictions? And I think that point is absolutely valid.
And there's a lot of stuff we see coming from different parts of the world, traditional remedies. Some work, obviously, some may not, but we do find them occasionally that people have known about for centuries or millennia.
It's definitely time to think outside of the box. We can treat pain in other ways. We don't often recommend acupuncture or uh, some of these other alternative therapies, but in certain cases, they can be life saving. They can be extremely useful. And you kind of made the point that it depends on the person. I think that's absolutely true. But the caller makes a good point. We need to think outside the box. We need to utilize all of our resources.
We talked about when I gave up tobacco. It's interesting because it happened right after I left a job where in the morning we'd have our morning meeting. It was at a TV station. And then a group of us would walk to the back studio where we had an outside weather deck. And we'd open the door and we'd all stand on the weather deck, rehash the meeting for about 15 minutes. Everyone would have a smoke. But I left that job, and all of a sudden, I wasn't surrounded by people who
Hmm.
smoked any longer. And so when I quit, I just stopped going to my local diner where I would have breakfast in the morning, and I'd have a cigarette while I'd have the breakfast, or I'd go, out for dinner at the same diner and have a cigar sometimes in the back room, where you could get away with all that smoke. But I stopped going to these places, and after about 6 weeks, I went back to them. But as I say, it was only about a 3 day withdrawal period for me, serious withdrawal. But I think I had dreams about it for about a year. So it will come up periodically with people in those situations. I also mentioned to you during the break, a lot of people find other things that aren't maybe as hazardous, but they substitute those. I was mentioning some friends of mine who had gone through the 12-step program for alcohol abuse, and then afterward, they never drank again, but they would get these big 20-ounce glasses of coffee and load them up with sugar. So people are finding other things that they substitute.
Yeah, I think, first of all, you make a good point in that behavior intervention is extremely important. We can't just focus on the medicine or the physiology. We've got to change behaviors. And that's true whether we're talking about smoking cessation, controlling alcohol consumption, or weight loss. We've talked about that a lot on this show. Behavioral medicine is huge. Um, and then to your point about finding substitutions, I think that is a good segue into this chronic pain management, which previously has really relied heavily on opiates, but there are non-traditional medications that can do wonders. For example, a lot of seizure medications can change the way nerves fire and therefore alter pain signals. So we use things like Neurontin or gabapentin, Lyrica, or pregabalin is the generic name. We use old antidepressants like nortriptyline and amitriptyline because even though they were never designed for for substance use or abuse or for chronic pain, they they affect the nervous system in ways that improves pain, that improves these cravings. And again, going back to the caller, we need to think outside the box. And like you had illustrated, we need to find other substitutions. Um, and I guess compared to alcohol, coffee and sugar isn't that bad. But you might be the person where coffee and sugar is your addiction, and so we've got to find something to replace it with.
There's that old George Carlin joke about how he said people talk about drug use a lot but don't recognize their own. And he says, think about the guy at work in the morning if there's a coffee pot and he's standing there saying, come on, come on, come on,
Yeah.
because he's got the caffeine addiction.
Oh yeah. Before we run out of time too, I wanted to just touch briefly on some of the things our patients can do. First of all, have a discussion with your provider about the medications you're receiving. Are they the safest option? Are they the most effective? Is there any addiction potential? If a narcotic pain medication is warranted, let's agree on the lowest effective dose, using it for the shortest duration. The second thing patients can do is make sure that they follow directions, resist the urge to self-medicate. Too many times I've had patients say, well, I overdid it and I had some more pain, and so I took a few more. I mean, you don't tell the oncologist to give you an extra shot of chemo because you feel like the cancer is not responding. You trust his judgment and you do what he says. Keep those medications locked up and put away. We talked a little bit last time about how a lot of folks are experiencing break-ins and burglaries because these people are looking for easy access narcotics. Um, and then dispose of them when you're done. Don't hold on to these things. This kind of plays into the previous suggestion, but the Twin Falls Police, I believe, have a yearly event where they collect all kinds of prescription medications,
Mhm.
narcotics especially. I've I've been told that funeral homes oftentimes have methods for dispensing of drugs that come in with the deceased, but you can do it at home too. Just mix them in with some type of undesirable substance. Maybe it's the used kitty litter, maybe it's coffee grounds, maybe it's that Tupperware, whatever in the back of the fridge that's growing fuzz on it. Just don't flush them down the toilet. Uh, don't dispose of them in such a way that they're going to be a contaminant.
You brought up a point when you mentioned people you're dealing with in the office. If you have a new patient and you have to come along and say, well, we've got some painkillers or something we're going to prescribe for you, if that person has been clean and sober for 20 years, you should still know that, right? Because they may have, if this is a person who's had addiction or dependency issues before, you don't want to, so they should give you that complete history.
Absolutely. First of all, we look for red flags, even if a patient doesn't recognize them themselves, or if they don't make those known. And for better or for worse, some of those flags are mental illness. If you're being treated for depression, we're very aware of the increased risk statistically, and we're very careful. But to their credit, I have had plenty of patients who have said right off the bat, I have an addiction history. I am 10 years clean, and I'm dang proud of it. Please do not give me anything that could be habit forming or addictive. And those people are absolutely an inspiration.
I was going to say, if you don't know this going in, I mean, this is going to impact how you would prescribe something, and you really should know that because you don't want to relapse.
Well, and there are screening tools out there to try and identify at risk populations, but unless you're in a chronic pain type of clinic, we don't utilize them. They just don't fall into the workflow. Primary care providers may not understand how to use them or where to find them. But again, better or worse, that's where a lot of these prescriptions are coming from. They're coming from your primary care doctor who is just trying to do his due diligence. He's trying to take care of you. He's trying to treat your pain while at the same time trying to manage your diabetes, your hypertension, your nail fungus, everything else under the sun. So take some of that responsibility and decide that you're going to do things differently.
I have a friend who's retiring at the end of the year from nursing and retiring early, but she has spinal stenosis and just was diagnosed last week with arthritis in her lower back. So she's looking forward to this retirement because she's been on her feet for a long, long time at the job. But I this morning I was listening to television while I was in the kitchen. It was on in the background, and there was somebody hawking one of these remedies on TV for lower back pain and the like. Should you be careful about anything you hear about on television about 4 o'clock in the morning?
Good question. As a general rule, yes, be suspicious of anything you hear on television at 4 o'clock in the morning. I think it's probably a safe guideline. But in all seriousness, as a as a healthcare provider, you have to know that I'm not going to recommend anything that doesn't have the best available evidence. And for better or for worse, that means there are a lot of maybe alternative therapies, or I don't know, more fringe therapies that I can't recommend. They could be great. You might really be interested in them, but I have to give you what I feel most confident about, what I feel is going to be safe, effective, predictable, reproducible. And a lot of these things that you might see on TV or hear about from your friends or read about, on page 10 of the newspaper, just don't have that kind of evidence. And if you want to spend your money on that, I'll help perhaps do it safely, but I'm just not going to give any paying customer advice that I wouldn't want myself.
I was going to say, be very careful to weed through this. If you see something and it sounds too good to be true, ask somebody at the doctor's office.
Yeah, that is such a good statement. I mean, it applies in so many different ways. If it is too good to be true, it is probably not true. This is a very complex issue. This is a multifactorial issue. It would probably be a little bit naive to think that there are just a few things that we can do here and there and rid ourselves of this problem. But I agree completely with that statement.
Very quickly, before we wrap up, contact information again.
Call us at 933-4400. Visit us on Facebook, Twitter. Remember, we're having our sports physical clinic tonight. I think it is a walk-in basis between 3 and 6 p.m. And we will make a donation to the team of your choice when you come in and get that physical done.
And of course, probably even a walk-in, but a call might not be a bad idea in advance.
Yeah, it might not, but we'll fit you in either way.
All right, want to thank Russell Singleton for joining us this morning. He's a physician assistant from Tripp Family Medicine here in Twin Falls, and we'll see you in the rotation sometime soon.
Absolutely.
Either that or walking back from Winco for lunch. All right, we've got news coming up next, and then we're going to talk a little bit about road repairs in Idaho. A bit of a follow-up to yesterday's discussion. That's on the way after news.